does with Vanderbilt Psychiatric Hospital and behavioral health. And so we have been doing this for several years, and we really enjoy this partnership. It's been terrific, and it allows us to have experts in their field. In this case, this evening, we're very glad to be welcoming Dr. Jamelleh, blew it. I blew it. Jamelleh Amouri. So practice that and everything. But Dr. Jamelleh Amouri here tonight to speak about psychiatric issues in children, and we all know that psychiatry is a special field, and we're losing. We've got a shortage of psychiatrists, and then when you get down to this particular field with adolescent and child psychiatry, we have even fewer folks. So it's always a pleasure to know that someone is going into that field and will be there for our children, especially as we now know that we're recognizing the mental health issues in children so much earlier than we used to. So I'm going to ask each of you to please mute your phones and or videos. And if you are on the phone and you're not sure, I believe, if I'm not mistaken, to mute a telephone is going to be *6. And if somebody knows otherwise, please share that. But I believe it's *6, and then you would just come off, I think, the same way. So I'm going to welcome again Dr. Jamelleh Amouri. She is a native Texan, and she went to college there and went to medical school there, and found her way over to us here in Nashville with her. She's completing her psychiatry residency here at Vanderbilt, and final year in child and adolescent psychiatry. So I'm sure they're going to miss you with that specialty. She's been in the fellowship program here at Vanderbilt, and not only is she looking forward to using her knowledge and skills, wherever you land, we are looking forward to your contribution to those families that so desperately need this. We really do appreciate it. And she loves working with kids because she believes strongly that early intervention can provide patients with the best possible outcomes. And we know that's very true. Here at NAMI, we understand that. And in fact, NAMI's national platform, one of their main platforms is early intervention. And so we do appreciate that. So if you will join me in welcoming her, and we will let you share your knowledge with us. We're going to withhold questions until the end. And we're going to withhold questions to the end. Don, I just saw your note. We'll take care of that in a second. So if you will allow her to share with us. I have one person, Robert Murray. You're one of our regulars.
Hi.
Hi, Robert. Would you do me a favor? You can mute your phone by hitting *6.
Okay.
All right. Let's see if that works. That did the trick. There we go. And then Kimberly is just getting on. So we'll let Kimberly connect, and then we'll ask Dr. Amouri to start once we know we've got Kimberly connected, and then we'll make sure that she is also muted. So, and I want to make sure we have nobody else in the chat. And that was Don. Great. Okay. All right. I think we're ready to go. Kimberly is still trying to get on, but I think we'll go ahead and ask Dr. Amouri to start. So thank you very much. And without further ado, the screen is yours.
Thank you so much, Robin, for the warm welcome, and thank you all for joining me tonight. I'm going to share my screen. Can y'all see that okay?
Yeah, we can.
Yes. Wonderful. All right, so I'm Jamelleh Amouri. I'm first year child and adolescent psychiatry fellow at Vanderbilt. I have 1 year remaining and will have completed my training at that point. I was asked to give a talk on this topic in particular, which is one that I am very interested in and have just a passion for caring for youth with psychosis. So I'm happy to be here with you all tonight. For those of you from Vanderbilt who are joining, I just want to say that I'm happy that you're here. And this talk was more so geared towards people with lived experience and family members and caregivers of kids or adolescents with psychosis. So it's not going to be as clinically geared as it might otherwise be, but I am happy to answer any questions at the end if there are any things that I didn't talk about that you have questions about. So to start off, I think it would be helpful to just kind of establish what is psychosis. Psychosis is a state of being that can disrupt one's thinking, perceptions, behavior, and level of engagement. In terms of disrupted thinking, sometimes we can see that people experience or exhibit paranoia, which can be an irrational fear, suspicion, or even mistrust of other people. Delusional thinking, which can be fixed or false beliefs that conflict with reality. And disorganized thinking, which can be disruptions in one's thinking that leads to either disjointed thoughts or incoherent thoughts. You can also see disruptions in perception, so how we perceive the world. So for example, auditory hallucinations are commonly seen in people who have psychosis, less commonly visual hallucinations and tactile hallucinations, which are the sensation of you actually feeling something on or in your body. We can also see disrupted behavior. So we may see bizarre behaviors or disorganized behavior. And what I mean by that is anything from difficulties with maintaining self-care, like personal hygiene, all the way to unpredictable behaviors. So what we would consider socially inappropriate behaviors or outbursts. And lastly, disruption in engagement. This is what we call negative symptoms, which basically consist of a decrease in emotional expression or a decrease in self-initiated purposeful activities. A psychotic disorder is what can be, you can see all of these things in a psychotic disorder, but what distinguishes psychosis from a psychotic disorder is that a psychotic disorder results in impairment in one's ability to care for themselves, relationships, ability to function in school or work or other similar settings. So that's what would be considered a disorder. What types of psychotic disorders there are really depends on a few things. So number one, duration of symptoms. There are different psychotic disorders depending on how long one has been experiencing psychotic symptoms. And another category would be the presence or absence of mood symptoms. So mood symptoms meaning depressive episodes or manic episodes. And whether or not the psychotic episode is due to a substance intoxication, for example, or withdrawal from a substance, or a medical condition. I want to differentiate or at least clarify around what a psychotic-like experience is and how we think about that. So a psychotic-like experience is basically a psychotic symptom in the absence of an actual psychotic disorder. And just like mood disorder or mood symptoms or anxiety symptoms, psychotic symptoms can exist on a spectrum from normal to disordered. So for example, you or I might experience anxiety, symptoms of anxiety or depression, but not necessarily have an anxiety disorder or a depressive disorder. This is very similar with psychotic-like experiences. These can occur in people in the general population, sometimes under times of stress. They can be part of certain like cultural experiences as well. So it's important to kind of differentiate between psychotic-like experiences and true psychotic symptoms due to a disorder. Psychotic-like experiences, though, are essentially psychotic symptoms, just not severe enough to be considered a disorder. And these can include hallucinations, delusions, paranoia, and magical thinking, which basically means it's a belief that one's thoughts or actions or words can cause or prevent some sort of consequence in their environment in a way that doesn't really align with how we understand cause and effect as a society. Psychotic-like experiences tend to be less severe and intense, less persistent and less frequent than true psychotic symptoms. And they don't typically cause significant enough impairment to be, considered a disorder. Now, here's some information on psychotic symptoms in youth. So in 9 to 12-year-olds, about 17% will experience psychotic-like experiences. That number decreases to about 7.5% in the 13 to 18-year-old population, and decreases even further once in adulthood, to 5%. So psychotic-like experiences are more common in childhood and adolescence than in adults, and over time are known to kind of go away or decrease. Usually, youth who are reporting psychotic-like experiences don't have and don't develop a true psychotic disorder, and they're usually associated with non-psychotic mental disorders like severe mood disorders, severe anxiety disorders, and trauma-related disorders. That doesn't mean we should just write them off or ignore them, however, because the having psychotic-like experiences does increase the risk of developing a psychotic disorder down the line, as well as other mental disorders like anxiety, depression, behavioral problems, substance use, and even self-harm and suicide attempts. So it is something to be aware of and not brush off. Some of the nuances of assessing psychotic symptoms in kids are some of the things we've already talked about. So age, for example, the younger the kid is, the less likely that the psychotic-like experiences are associated with a true psychotic disorder. Culture can also play a role, as well as cognitive and brain development. The other thing to keep in mind in the young population in particular is that overactive imaginations and having vivid fantasy lives can sometimes be misinterpreted as psychosis. So for example, imaginary friends. And something that can help us kind of distinguish between true psychotic symptoms or not is if they're really situationally specific symptoms, like they only hear the voices when they're upset or at bedtime. If they're overly elaborate, so very detailed and formed, and if they occur, without evidence of other psychotic symptoms, then it's probably not a true psychotic disorder. So just things to keep in mind. There are also a lot of things that look like psychosis in young people. In people with obsessive compulsive disorder, they frequently struggle with obsessions, which are recurring unwanted thoughts that can be really irrational in nature and can appear to be paranoid or delusional, depending on the obsession. Anxiety disorders, so a lot of people with anxiety disorders really struggle with anticipatory anxiety or anxiety about what might happen in the future. And that anxiety can become so extreme that it almost appears delusional or not really fixed in reality. People with depression may struggle with ruminative thoughts, which are repetitive, almost obsessive negative thoughts about themselves or about the situations that they're in. And these can also progress to a point that they appear irrational. Post-traumatic stress disorder is another really big one that I, in particular, want you all to kind of be thinking about. So in youth who have a history of trauma, they could experience post-traumatic stress disorder, which can include flashbacks, which to an outsider might look like they are responding to things that are not really there in the environment. So they might seem like they are hearing or seeing things that are not there. They can also exhibit hypervigilance, this constant being on edge, being easily startled, which could appear to be paranoid to someone who doesn't know that they may have post-traumatic stress disorder. And some people can even experience dissociation, which is essentially a disconnection from reality and oneself for a short period of time. Other developmental disorders like autism can present with signs and symptoms that may appear to be psychotic when they're not really. People with autism often have repetitive, obsessive sort of thoughts. They may have unique or unusual beliefs about the world. And they may also struggle with social reciprocity, which may appear more on the end of negative symptoms of psychosis, but it may not be psychosis at all. In people who have attention deficit and hyperactivity disorder, they really may struggle with concentrating, which could disrupt their ability to form coherent, organized trains of thought, which could appear like disorganized thinking. And lastly, those with language and cognitive deficits really could struggle with communicating coherently, and that could also present as disorganized thinking. So it's important to be thinking about any other things that could be contributing to what you're seeing. Now, in terms of actual psychotic disorders in youth, childhood onset schizophrenia, or the onset of schizophrenia before age 13, is exceedingly rare. Fewer than 1 in 10,000 kids will be diagnosed with childhood onset schizophrenia. Adolescent onset schizophrenia, which is also known as early onset schizophrenia, presents between the ages of 13 and 18, and it's also fairly rare. And usually the onset of psychosis or schizophrenia is later in adolescence or in the early 20s. Now, some actual causes of psychotic symptoms in youth. We talked about schizophrenia as being one. We have bipolar disorder and major depressive disorder that can present with psychotic features if they become severe enough. So someone experiencing severe episode of depression or severe manic episode could also present with psychosis. Schizoaffective disorder is another diagnosis that we commonly see that is associated with mood symptoms as well. And of course, certain substances can produce psychotic symptoms, and withdrawal from certain substances can produce psychotic symptoms as well. And lastly, medical conditions such as seizures, autoimmune conditions, central nervous system infections, genetic syndromes, are things that can produce psychotic symptoms in youth as well. Things that would warrant more of a medical investigation would be like neurologic deficits or findings, more physical symptoms like rash, fever, abnormal movements, and known exposure to certain like toxins or substances. Now, some risk factors for psychotic disorders, and there are several, many of which I did not include here on this slide, but I think these are kind of the main ones to be aware of. So complications during pregnancy, including infections or severe stress, and the mother can predispose her child to developing a psychotic disorder. A family history of psychosis is probably the most important risk factor to be aware of. Certain genetic syndromes can present with psychosis or put someone at risk for developing psychosis. Abnormal development of the brain can also predispose one to psychosis, as can childhood trauma, severe stress, psychotic-like experiences like we discussed, and cannabis use, especially prior to age 13, or if the onset was prior to age 13. And I starred family history of psychosis and cannabis use because they kind of go hand in hand sometimes. So when we talk with youth about the risks of using substances, we know that youth with a family history of psychotic disorders, so close relatives that have diagnosed schizophrenia or bipolar disorder, psychotic features, or schizoaffective disorder, these youth are particularly vulnerable to developing psychotic disorders if they are also using substances. And if someone already has a psychotic disorder, using these substances can also worsen their existing symptoms. So one of the major players is cannabis, as well as synthetic cannabinoids. And this is probably one of the most strongly associated substances with psychosis. Stimulants like cocaine and methamphetamine are also risks. Dissociatives like PCP, ketamine, and dextromethorphan, which is frequently found in cough syrup. And lastly, hallucinogens like LSD or psilocybin mushrooms can also predispose one to invulnerable people can result in psychosis.
Doctor, forgive me for interrupting, but is there any way to make your voice a little bit louder?
I can try to speak louder.
Thank you.
Is that better?
Yes.
Okay, sorry about that. So now I'd like to talk about some of the early warning signs of psychotic disorders. So there's something called the psychosis prodrome, which is basically a period of time between normal functioning and the first episode of psychosis, where there are actually some symptoms that are kind of vague and nonspecific and really unclear what might be going on at that point. So during this prodrome, and this can be, months to years before the first episode of psychosis, one might exhibit social withdrawal, so becoming more isolated, low energy or motivation. They may exhibit changes in their sleep or eating patterns. They might become less concerned with appearance and hygiene. They might start to seem a little paranoid or suspicious of others. They might also seem, more anxious than usual, or just their personality is changing. And lastly, feelings of unreality, meaning, they have this sense that things around them may not be quite right, or they may start to feel disconnected from themselves or from reality. And this is a population that we consider to be clinically high risk for psychosis. However, these people are often misdiagnosed as having depression or anxiety disorders simply because they, a lot of these symptoms look like depression or anxiety. So the social withdrawal, the low energy or motivation, changes in sleep and appetite, self-care, all of those could be symptoms of depression. And of course, a lot of times this prodrome is occurring during adolescence. So a lot of people may just chalk it up to, oh, they're just being a teenager. They don't want to socialize. But truly this population, considering all of the factors, could be at high risk for psychosis. It's important to be thinking about. There are efforts ongoing currently to try to identify youth in the early stages of psychotic disorders. What we know is that around 1 in 4 people with prodromal symptoms will progress to psychotic disorders. So not just any one of the symptoms, but if you have like this whole picture that seems very prodromal, about a quarter of people will ultimately develop a psychotic disorder. We know that early intervention has been shown to improve outcomes, and there are several programs in various medical centers across the country, including ours, with a specific focus on both research and intervention for people in the early stages of psychosis. And those interventions have really been shown to improve the prognosis in terms of more of the chronic psychotic disorders. So some of these interventions, which for some people are more likely to delay conversion to a psychotic disorder rather than outright prevent it, include preventative strategies would include more of like targeting stress, making sure kids are sleeping enough, getting enough that those are being appropriately treated. Other interventions include education, so providing kids and their families with education about what psychosis is and what prognosis might look like and what treatment might look like are really important. Therapy, including cognitive behavioral therapy for psychosis, family therapy, and social skills training for youth are really important. Medication can definitely play a role depending on where someone is in their illness. And lastly, omega-3 fatty acid supplementation, where the data is not totally conclusive, but there definitely have been studies that suggest that supplementation with omega-3s can reduce the conversion rate to psychosis and improve symptoms and just overall functioning in some adolescents who might be ultra high risk for developing psychosis. Now, as caregivers, I would encourage you to learn as much as you can about psychotic disorders. Ask your youth about psychotic symptoms or psychotic-like experiences, not necessarily because you're super worried about it, but more so, something to keep track of if they are experiencing them. Some kids and teens may not, volunteer that information. So it's important to ask. Also, paying attention to really significant changes in their personality, their motivation, thinking, behavior, and decline in function, which might signal the onset of like a prodrome. If you have concerns about psychotic symptoms in your youth, really getting an evaluation from your pediatrician to start off with. The pediatrician can help determine whether a medical workup is indicated depending on what the symptoms are and if there are other signs that are concerning for a possible medical cause. They can also help refer to a psychiatrist or psychologist who can, more clearly distinguish between psychotic-like experiences and symptoms of a true psychotic disorder. Also encouraging abstinence from substance use and trying to determine whether substance use is playing a role at all is important. And being able to support their adherence to treatment if treatment is started. That's one of the factors in terms of prognosis that we really try to drive home for families is if they can, encourage youth to stick with treatment, the outcomes are usually much better. And of course, what can you do if you're trying to take care of yourself and someone with a psychotic disorder? I think one of the most important things is to make space for grief or whatever feelings you may be having about taking care of a loved one with a psychotic disorder, because it's not easy. Finding support groups like through NAMI could be very helpful. And finding ways to regulate your own stress and your own emotions, because we know that individuals with psychotic disorders can be very sensitive to environmental cues, including changes in their loved ones' emotions and behaviors. So learning new ways to regulate our own emotional responses, we can model that for our youth as well. And of course, making sure that you are eating well, sleeping well, trying to get exercise, trying to find time to relax, and also to have fun, because those are also important things to model for your loved one. I think that's all I've got. I'm happy to take any questions or comments from anyone at this point, and appreciate all of your time.
And so what I'd like to ask is, can we, yeah, thank you. I wanted people to be able to see you. So thank you for doing that. I don't know if anyone else has a question, but I think one of the questions I have is, how much are pediatricians trained to be looking for the prodromal phase and the characteristics that are within them? I know I don't think they get a lot of training period on behavioral health.
I don't know the exact answer to that, but my suspicion would be that they're not really trained to recognize the prodromal period. I would say many mental health professionals don't really know a whole lot about it either. So my guess would be pediatricians probably wouldn't.
And just on top of that, do you think that they might mistakenly take it for depression, which might not be bad if it gets somebody into a mental health professional that could then correctly diagnose it?
Yes, so oftentimes the prodrome may appear to be depression or anxiety, and one of the benefits of that, I guess, is that they may get on treatment for any depressive or anxious symptoms they might be experiencing, which in terms of prognosis and conversion to a true psychotic disorder does have some benefit. But yeah, if it helps them get connected to a mental health professional or some sort of agency with services, I think that's one of the pluses of that.
Okay.
Yes, doctor, I had a question about the omega-3 supplement.
Mm-hmm.
How does that help? And is it also helpful for adults?
That's a good question. I don't know that we have an exact understanding of how it helps, but we know that the brain is made up of, significant like fatty acids, essentially. And there have been some studies that have shown that in the brains of people with schizophrenia or chronic psychotic disorders, they actually have, lower amounts of fatty acids, of the good fatty acids in their blood. So that may be in some way how it's kind of mediating that effect. Also, omega-3 fatty acids are anti-inflammatory in a sense. And there are some theories about how schizophrenia develops. I think it's very much multifactorial, but one of the theories may be related to inflammation of some sort. So that, I think, that's all I know. There may be other explanations I'm not aware of, but it's a great question.
Thank you.
Yeah.
Hello.
Hi.
My name is Kenneth. I have a question for the doctor. Can you hear me?
Yes, sir.
I had 3 kids. I lost one son to suicide, schizophrenia. He developed it in his 20s, early 20s. He's actually on his way to pharmacy school, and he had an onset of it and committed suicide. I have a second son that was identified, who I have who's living now, that's around 15, started having episodes. I think this prodrome thing you talked about, we got him quickly up to the psychiatrist, and later it's developed into the psychosis and full-blown everything right now. My question is, I was present when all 3 of my children were born. I saw both of my sons, I witnessed both of my sons all my children being born, and both of my sons, when they were being born, had problem pregnancies. I informed the doctors that on my oldest son, he had an 18-hour long-term pregnancy, and when they went to get him, they had to go get forceps. They jumped on my ex-wife's stomach. You know, it was a difficult pregnancy. That's the first son. My daughter was born perfect. She just came straight out. I witnessed this. I'm in the operating room. My second son, he's born with a biblical cord around his neck. And it was so tight, the doctor had to rewrap it back around. His little heart was jumping out. And he was in there twisting the baby back and forth. And like I said, the biblical cord was around his neck. Both of these sons of mine developed schizophrenia. And I heard you say one of the identifying possibilities is problem pregnancies. I don't understand why no doctor has ever x-rayed my son to see whether or not there's brain damage, or I mean, why, if it's something that's caused by pregnancy, maybe low oxygen or whatever, I don't know what it is. I don't understand why there's never been any x-rays of my present son's condition. How do we know? How do you know it's not brain damage? I mean, something that's looking like schizophrenic, but it's really, he has partially his brain maybe damaged. Why hasn't that not been ruled out by 3 psychiatrists? I don't understand.
Yeah, Kenneth, I appreciate you sharing your story, and I'm very sorry for the loss of your son. That is an unfortunate possibility with people with schizophrenia, that they, may develop suicidal thoughts and even act on them. In terms of your question, you're absolutely right that those pregnancy and delivery complications could have increased the risk for developing schizophrenia. I don't want to say it was the only reason. I think there probably were other reasons, just as there are with every person. And the unfortunate truth is that we would treat it the same way. If he was experiencing psychotic symptoms because of brain damage, or because of a strong predisposition to schizophrenia, it would be treated with the same medication. Now, if there was someone who there was concerns for like neurologic problems, like they had weakness in one of their arms, or they lost sensation somewhere on their body, other things that would signal a significant lesion or damage in the brain, that would be a reason to certainly use imaging to try to see what's going on in the brain. But unfortunately, I'm not sure that it would change a whole lot in terms of the approach to treatment, if that makes sense.
Okay. Because I guess if you know that problem pregnancies could be a possible determinant for this, I don't know. It seems like to me, I mean, I hear what you're saying. You're saying that if it's something that showing other signs of brain damage, it may have revealed itself prior to the onset of schizophrenia. How do you all come to find out that problem pregnancies are a potential problem, that are a potential cause of it? Somebody had to do some research to determine that.
Mm-hmm. Yeah, I think that there have been studies that look at people who've developed schizophrenia and then ask them questions about, all kinds of different things. Like they'll ask their family members if there were any complications during the pregnancy or delivery, if there were any early childhood, like significant stressors or traumas, any of those risk factors that could predispose one to developing psychosis, would be things that they would ask those participants in the study about, and then compare, people who have schizophrenia versus those who do not. And, that's how they kind of determine what risk factors are.
do they spend a lot of money in researching schizophrenia, since schizophrenia is such a low percentage of people that have it? Is it something that's on the back burner in terms of money being funded to do research for cures or possible other treatments? Is it something being neglected?
I wouldn't say it's been neglected. I think there's definitely been more of a push to study schizophrenia and to study the brain basis of schizophrenia. So what sort of changes go on in the brain, even on a microscopic level, to potentially result in symptoms of schizophrenia. So I know that that is research that's being done all across the world.
And Jamelleh, I'd like to speak to that too, in that I know the National Institute of Mental Health has had the RAISE study. There really has been a bigger push on this. I think we are seeing more research. I think that psychiatry was a science that really isn't that old in the modern sense of science, but I think we're making some strides. And the other thing, Kenneth, that we're seeing is a real focus on psychiatry and research in youth, just in what Jamelleh has been telling us about in terms of catching it early. We're just understanding that early. Jamelleh, I was just wondering if Kenneth or any of us were to go to the National Institute of Mental Health. I know they have their own YouTube page, but I just wonder if there might be a way for him to look up if there have been any studies specifically with that, with pregnancy and schizophrenia. It's certainly, Kenneth, you certainly have gotten my interest piqued on that.
Yeah, I'm not aware off the top of my head if that would be something you could find on the NIMH, but I'm just doing a quick.
It seems like somebody need to be studying me. I actually witnessed this. I was in the room. I saw this happen, and 2 sons of mine developed schizophrenia.
Yeah.
The disease, and they were traumatic pregnancies. And, and also it seems to be a disconnect between once the doctor's level, and then, you get them and you start trying all these medications. And, my son has had this illness since he was 16. He's now 25. And I can't even get someone to say, hey, look, I'm willing to go pay whatever to put my son in a study. Just if you want to study, I don't even know of any studies in this area that are, like programs. I see them in Florida, I see them in California, I see them up north. I don't see anybody, any kind of, people want to participate in studying schizophrenia in the South anywhere.
Okay. And I was going to say, if you'd like, get in touch with me, because, we're certainly aware of some stuff. I don't know anything specifically going on, but call me. And, these are things that will help with. The other thing is, as far as being a parent, coming into the support groups, sometimes what will happen is somebody will show up in that group that has been down that road, or they've experienced that, or maybe they're coming from another area and they're new to us. And so that sometimes it's, how we pick up some of this information. And then other times it's, for instance, when Dr. Heckers gives his talk every September, October, updating us on the research, and then having people like Dr. Amouri here, come in. So give me a call. You've got me curious too. So feel free to call me at the office and let's see what we can find out.
Okay, thank you.
All right. I did have a question. Does anybody else have? I don't want to. If anybody else has a question, I certainly want them to ask. But I do have another question regarding ketamine.
I do have a question. Thank you, Dr. Amouri, for that great overview. This is just in reference to kind of the prodromal symptoms that you mentioned of schizophrenia, and I hope this isn't too clinical, but how you had mentioned that there's a large percentage that are misdiagnosed with depression, and so I guess what are the differences between an actual initial diagnosis of major depressive disorder versus when would you be suspicious that this depression is actually prodromal?
That's a great question, Kimberly. I think that you kind of have to look at the big picture and not get so bogged down in terms of what the specific symptoms are, because like I had discussed, so many of the prodromal symptoms are very much overlapping with symptoms of depression. But some of the things that would not be consistent with, symptoms of depression would be some of that like suspiciousness of others, developing paranoia, maybe those early sort of changes that start to seem a little more psychotic in nature. So the feelings of unreality, the suspiciousness, kind of the like decreased concern in terms of caring for themselves or their hygiene and things like that. Some of the more isolative behaviors, which also there's still overlap there, but looking at the big picture, I think for some clinicians, it almost becomes like a spidey sense in a way. So I know that's not really helpful for you to hear as a first year resident, but I think with time, as you meet more people who are kind of in these early stages of a psychotic illness, you'll kind of see how it differs, if that makes sense.
Yeah, that makes sense. Thank you.
Do we have anyone else with a question? I think, Dr. Amouri, one of the things that I had, I noticed that we were talking about, ketamine lending itself to psychotic disorders, but now we have a big push right now in ketamine for depression in adults. And so how does that, how does that work when we're worried about, kids and, creating issues, with medication?
That's a great question, Robin. To your point about ketamine being used therapeutically for treatment-resistant depression, the doses that it's given in, or that it's given for treatment of depression is usually much, much lower than what one might take kind of recreationally to get high. So that I think is one thing, and also the like amount of exposure and over so much time. If someone is a recreational, like frequent user of ketamine, I think that is very different than what we see in terms of a clinical setting, giving low doses in a controlled setting and taking into account, what to be on the lookout for in case people have some sort of an adverse reaction.
Thank you.
Yeah. And I think we have some information here by Alexandra regarding the early psychosis program at Vanderbilt, if y'all can see in the chat, because there is research ongoing in our department, like I had alluded to. And then she also mentions the NIMH has a science news feed that details updates on research on various conditions, as well as changes in funding. So for you, Kenneth, I think that those could be some useful resources.
And Kenneth, that newsfeed for the NIMH is actually on the front page of our website. We get a daily feed from the NIMH. And the other thing I wanted to address to Kenneth was there was 3 years ago at the NAMI has a national convention that always includes research. And I know 3 years ago there was some presentation on bipolar disorder, not schizophrenia, but bipolar disorder and research during pregnancy. And it was very, I just remember, I don't remember all the details. I remember it was very interesting. So I do think there are, possibly some things out there. And Dr. Amouri, we don't expect you to have all of those at the tip of your tongue. But we do appreciate what you can bring to it, and what else, things like Alexander is sharing. So yeah, together we can all, we can all, look this up and And
I have tried. I've contacted people in other states. I'm willing to travel, move my son to whatever state. I cannot get in any program. I can't get people to contact me. The doctors, they're doing the best they can. I appreciate they trying medication. It's 90% seems like this medication. I get that, but they don't seem to have any resources, that deals with the therapy piece. Schizophrenia is a very complex illness.
And Kenneth, one of the things going on right now at Vanderbilt that's fairly new. There's Dr. Aaron Brennan who's come in and he's doing CBT for psychosis. And
Okay.
so that's something new that has Dr. Heckers has brought him in for that specialty out of the Beck Clinic that was in Chicago. So
How can I get in? How can I get in?
you know what? Let's find out. I'm not sure how that works, and we'll see what we can do for information that way. There are some specifics. This is I know it's very frustrating for people a lot of times to get into some of these programs, but let's like I said, contact me. And
Okay.
yeah.
Thank you.
You're welcome. I understand your frustration. I had a sister with dual diagnosis, developmental delays and schizoaffective disorder, and a dad with paranoid schizophrenia. So for families, it's just so hard to watch it go on.
It is. It's very hard.
And when you lose somebody and you've already lost somebody and you see it happening again, that's got to be scary as heck.
Yes, it is.
Yeah.
Thank you.
Mm-hmm.
Robin?
Yes.
This is Kelly, and I work actually in the psychosis lab at Vanderbilt.
Yeah.
And so I work with like the therapist and the psychiatrist and the psychosis team there. So I'm happy to make that connection and facilitate a referral. Kenneth, if you would like to do that, I'm happy to do it.
I would certainly appreciate it. I would appreciate it. I'll do whatever I need to do. My son right now just got out of a mental after his 4th time being in Rolling Hills Psychiatric, and the medications they try on him, they're doing the best they can, but he's in psychosis now. I mean, I've tried to go to Parkview today he is not even in reality. This is a very, as you know, very serious illness, and it's life-threatening. He's attempted suicide. So I've actually had 2 kids who have attempted suicide. One was successful, and I got one right now that could possibly kill himself. So I just really need some kind of connection, really, really bad. I'm worried about my son.
And Kenneth, I think Tiara, you went through the With Hope in Mind classes, right?
Yes, ma'am. I sure did.
And so now it might be helpful, Kenneth, for you to go through. It's very similar, but we're doing the family to family class, which is the 8-session intensive for family members, and it includes not only the clinical aspects, but how to have how to talk to someone that is in psychosis, different things that we do as evidence-based practices that NAMI has developed, that are national practices for us, that might be helpful, for you and engagement. So that for any of you out there, NAMI does an 8-session intensive class. Like I said, it's an evidence-based class. It's a national signature program. And 80% of the people that come through the class, because we do a pre and a post test with every class we do, 80% of the people that come through that class will have stated that they've reduced the level of crisis in the home. They're better able to communicate with their loved one with a mental health issue, and they're taking better care of themselves. And so it might be something, to take a look at. And those of you that are interested in that, you can get on the NAMI-Davidson.org website and look under the education tab. It's the first thing you'll see under the education tab. And for those of you at Vanderbilt, please feel free to refer your family members to that. I always tell people, you know, nothing's magic. All the magic fairy dust is gone. But, you know, anything that we can do to help, even incrementally, makes a difference in getting us to where we want to go.
Her information, how can I get her information? Got me. Can I give her my email? Where's she at?
So as you guys are looking for that, are you looking for the contact for the referral?
Yes.
Okay.
Yes.
Actually, we can direct you. We were working with Dr. Brennan earlier this year and would be happy to direct you.
Okay.
To that.
Thank you.
And I appreciate those of you.
I included my email in the chat too.
Did you?
Okay.
Great. Thank you.
Yep.
And we appreciate you guys in the psychosis program. We've got a long history with Emma Finan and Dr. Hecker, so we do appreciate what's going on over there.
My name is Denise Freitag, Kenneth, and I looked at the family to family class and I realized that Davidson chapter wasn't offering it until later in the fall, but the NAMI Tennessee chapter actually is offering it via Zoom starting June 5th. So if you just look up NAMI Tennessee, you can find it there as well.
All right. Thank you. Thank you.
Thank you all for helping with those resources. I appreciate the support.
Yeah, my son is just recently diagnosed with schizoaffective disorder, and I wish he was in Nashville to take advantage of all of this, but he's currently in Minneapolis. So we're supporting long distance, which is tough.
Denise, there is the NAMI up there is excellent in Minnesota. I belong to a national network of executive directors.
Oh,
happen to know that director up there for Minnesota. She's terrific. And so the other thing is, we had a family one time that the mother was here, the person they were concerned about was in Florida with his wife, and another brother was in Alabama. And they all took the class, the wife, the mother, and the brother, all took that family to family class at the same time, so that they could be on the same page and where they were. And so they could be on the same page when working with the one that they loved and they cared about. So so you could, just like the class you mentioned in June, or even ours is going to be back to in-person in September, you could take a class here and still learn things, because it's going to be the same class they're teaching in Minnesota.
right.
And still do that. And then if you want resources up there, contact the NAMI up there. I'm happy to do a warm handoff,
Okay.
you know, for that kind of thing.
Okay. Thank you.
Mhm. You know, this stuff is not easy, folks. We know that. We're all living, you know, and those of you that are in these programs, those of you that are in the professional world, usually there's something that draws you into this field. There's usually something personal. You know, occasionally I'll get somebody that I talk to master's level, or even rarely doctorate, but you know, well, I just find the brain so interesting. Well, yes, it is. But generally what happens is you had an experience yourself and you want to know why. And a lot of times that's what draws people into this field, or they want to know about themselves. And so we appreciate, you know, everybody that is willing. This is not a field. You don't jump into this field, you know, for the glamour. You jump into this to make a difference because there's something spoke to your heart, and you want to dive in. And so we so greatly appreciate that. So I'm going to give one last call for questions, and if I don't hear it, then I am going to thank Dr. Amouri for her presentation, and all of you too for asking the questions that you did. Dr. Amouri, thank you for taking the time to develop your presentation and share it with all of us. We really do appreciate it.
Thank you for having me. It has been a really wonderful experience, and I appreciated getting to talk with you.
Terrific. And yes, I see a hand, you know, in our Zoom, the hand clap for Zoom. Thank you, Kimberly. So we appreciate your time tonight. And you know, there are resources out there, guys. And for local resources in Nashville, you can check out the NAMI Davidson website under groups/resources. There are all kinds of different resources under there that you might want to check out. And that goes for you practitioners too. Everyone, I do hope you have a nice night. It's springtime, so we still have some lightness outside, which I adore. So thank you. And if you would like to know more about what we've got coming up, then just go onto our website and sign up for you know, to get information, so that we can share with you what we've got coming up next, or just check our calendar and click on that way. Thank you again, Dr. Amouri.
Thank you all.
Thank you.